Absolutely. Thank you for that intro, Susan. It's a pleasure to be here. I pinch myself every time I get the opportunity to present with Fred. He's a kind-hearted doctor as well as being pretty darn brilliant. So it's an honor to be here and to present alongside.
You're too kind. You're too kind.
It's the truth. It's the truth. So, for everyone who's joining us here tonight, this is a conversation, a discussion, a presentation that sort of arose or sort of organically between Dr. Wininger and I as we were talking through some cases and having these conversations about sort of what gets referred to neurology, what gets referred to behavior, where we might actually have some overlap between the disciplines. And so we thought, well, wouldn't it be fun to put this out there to everyone and give you all the opportunity to weigh in and have the opportunity to really share some of these cases with all of you. Anything else you want to say, Fred, before we dive in?
Yeah, I'm excited about it as well for the same reason. I mean, when we have these cases that come in with these nebulous kind of signs that are these repeated behaviors or all the things we're going to talk about, it can be such a challenge. And I'm really excited to just kind of talk through some of the ways that we try to differentiate them as best we can. So.
That's awesome. And so, one of the things to just kind of set this stage here is that, one of the things that both Fred and I hear from practitioners and from other specialists is, here I've got this case in front of me. The owner is describing it. Maybe they're showing you a video, or maybe you're seeing the pattern, whatever it happens to be in consult. And you know that it's, as I often say, above your pay grade. And by that, it doesn't mean that the specialist is above or below. It just means I don't know what I'm doing here. This is beyond my capacity and for my understanding. So who do you call? If you're looking to phone a friend, so to speak, who do you call? Where would you refer? Do you grab the neuro text? Do you grab the behavior text? If you're going on VIN, which message board are you going to post in? Even just that big picture idea of who is it, behavior or neuro? And especially if we're going down the medication pathway, are you going down the anticonvulsant pathway? Are we looking at anti-inflammatories? Are we treating for pain? Are we treating for some degree of anxiety or compulsive disorder? What are we reaching for? And so before we get too separate within this conversation, I also want to draw us back to the overlap in that, we intentionally titled this Brain or Mind. The idea, sort of the structural, functional, how does the brain work and how it controls motor patterns, but also emotional regulation, right? That's sort of the mind, the cognition. Is the animal able to process not just sensory stimuli with reflexes, but processing actual inputs and making sense of them cognitively, emotionally, and so on? So where does this sort of overlap exist? And also, where do the separations really delineate themselves out?
Yeah, I
Any
mean, I
additional
think
thoughts, your friend? Yeah.
Yeah, I think that this is the common conversation that you have behind should I go see a psychiatrist for my headaches or should I go see a neurologist or an epileptologist and try to figure out what's causing them? So I think there's the obvious structural overlap that the things that control behavior are parts of your brain. That's the obvious one. I think the ones that are less obvious but still important are some of the repetitive behaviors that we see, the frequent movements, the gait abnormalities. Those can be pure motor dysfunction somewhere outside the nervous, outside of the brain, rather, in a different part of the nervous system or perhaps in the muscles. And so we're going to get into that as well.
Yeah. Fascinating. Before we get too far into the meat or the heart of the conversation here tonight, I do just want to put a little love out to the sponsors. We wouldn't be here chatting with all of you today if we weren't sponsored to be here, right? We have the wonderful opportunity to collaborate with the folks at Zomedica, and thinking about not only the products that they put out there, but just the effort that they put into education for the veterinary profession. And so we do have some products that are listed here, whether it's the Assisi loop or the Calmer canine, like you see in the Calmer canine, excuse me, like you see in the bottom left. We've got a variety of different options that do have an overlap within this conversation. But truthfully, we're here because they support the work that we are doing, and in turn, we support their work as well. You ready to get started with some videos, Dr. Wininger?
Let's do it.
Excellent. So here's where that first disclaimer comes into play. We've done the best we can to troubleshoot bandwidth issues. If on your end, if there's any sort of delay or lag, don't worry about it. We will be able to walk you through sort of what the videos show, but we'll give you the opportunity to weigh in here just a little bit as well. As we get started, one of the things that we're going to be looking for is sort of the idea of even answering that question: is it behavior or is it neuro? If you see something, by all means, go ahead and throw your comments, your questions into the chat. That should be enabled on your end as well. Hopefully everything has worked well with the setup on that. Go ahead and throw that in, and we should be able to see that on our end and give us a little bit of a decision tree there. Behavior or neuro or behavior. What do you think? Let's get started.
Oh, I had this one when I was crying.
Oh, that's cute.
Remy.
Remy.
Oh.
Yeah, so I'll start off with this one, Chris. Basically, what we can see the chat if you guys want to throw some ideas in there of things that you're seeing. But while we get that started, one of the things that can be challenging is these dogs that come in and they are somewhat reclusive. They are somewhat not themselves. They're not interacting the same way. And so we're looking for cues that could tell us what the nidus of that is. And so when I look at this beagle, what I see is a low head carriage. I see the bottoms of the sclera, so the dog is kind of looking out through the top, directly through the top of its eyeballs, like we like to say. And also you could see going into that little bit of a praying position. And if you are really astute, you could pick up on muscle fasciculations in the neck. So this is an example of cervical hyperesthesia, but it's or cervical pain, but it's very easy to mistake that for a behavioral abnormality.
And I love when I look at that video, the first thing that I notice, even before there's any movement there, the tail carriage is a bit low. And so somebody might say, oh, wait a minute, is this animal fearful? Is there a negative emotional response? And we're seeing an overall level of inhibition within that body movement. The answer is yes, but the bigger question is why? Right. And so what I look for then, I say, well, yes, this dog is inhibited within the body language, but it's also moving freely around the space. If I have a dog that is showing a fear-based reaction toward, let's say, the person in the background or the person behind the camera, I'm more likely to get an avoidance response. There's going to be a direct relationship of the movement pattern, either checking out that stimulus, whatever it is, or avoiding it. And here we have an animal who's, again, in their three-dimensional movement within spaces, moving around relatively freely. When it goes into that little bit of a prayer stance, sometimes we'll see that with an animal, again, who's releasing some tension if we're seeing some fear, anxiety, or stress, but it's super inhibited. And so, again, whether that's in this case discomfort, or we could see a similar pattern where we've got, again, just a little bit more of that inhibition piece that's there. But putting the pieces together, I would be absolutely screening this for discomfort, screening this for pain. And so I would say, from my standpoint, I'm going to punt this one over to Dr. Wininger before I start to weigh in at all on emotional responses here.
Yeah, the one thing I was going to add, just from a technical standpoint, is I think the chat isn't working the way we want. So if you guys want to throw comments in the question and answer box, I believe that's working. So go ahead and do that, please. Let's do the next one, Chris.
That's perfect, and thank you for that. Next video. What do you think about this one, Fred?
Yeah, can you play it one more time? I may talk over it while you do that. So, one of the things that we always talk about when we're trying to differentiate, behavior problems from neurologic problems is the presence of laterality. And so what you can see in this particular patient is he has a little bit of a head turn to the right. He's starting to list to the right. He has if you're really astute, you could pick up on a little bit of offloading of that left thoracic limb, which likely represents a proprioceptive deficit. So an inability to pay attention there. Do you see how there's a little bit of twist to the wrist there? And so when you see these kind of one-sided signs, this propensity to turn in one direction, deficits on the other side, things that just don't look right on the opposite side, to me, that's going to speak to a neurologic problem.
I love that. And you mentioned that left-sided paw lift or that laterality. One of the cool things there, and again, this is the dialogue that I love having with Fred, is that I look at that and the difference between looking at that as a lateralization versus if we have an animal who's showing some degree of fear or anxiety, we'll often see a paw lift as a hesitation. With that being said, their stance is usually square. It looks different from a lateralized sign, and it's a very intentional movement, and you'll be able to correlate that with the rest of their body language in relation to what's happening around them. So even some of those things where if you're describing this or the client is describing it, and they may say, oh, and then it lifted up his paw. Okay, how? It's the subtlety and actually being able to visualize it, whether that's with video or seeing it in real time, is so important to be able to tease that out into a clear neuro lesion or into a clear behavioral, body language communication detail. Thinking about the body language here, we're going to shift gears just a little bit with these next two videos. The next two are actually the same patient. I'll let the first one play.
While you play that, I wanted to jump in here. We have enabled the chat. I don't know if any attendees want to throw a test out there in the chat box to see if we can see. I know some people had issues saying it was disabled, but we've enabled it. So if someone could throw out a test chat, that would be great.
Well, that's all happening in the background too. Looking at the body language that you see within this particular patient, what I love about this particular clip is this is a dog who has both fear and anxiety issues. And so rather than seeing any of the lateralization that we've seen in some of the previous videos or that inhibition due to discomfort, this is an animal who's moving relatively freely throughout the space. And yet, again, if you're astute, you're seeing that stretch as that animal sort of anchors those back legs and is stretching that nose out to be able to gather information from its surroundings. And then when it gets a little bit overwhelmed, you see it backing up again. So again, this is often what we consider to be an approach avoidance, sort of a response as an animal is gathering information, but is showing signs of emotional discomfort within that environment. And so we see that clear relationship between their movements contingent on what's happening. This is a dog who is sniffing the environment after a visitor has come and gone. So an animal who has more of a stranger danger, fear-based reaction to unfamiliar people. Any additional comments on that one, Fred?
No, I agree. I'm with you on that one.
Excellent. And it looks like
Chat's
cool.
working.
Chat's working. That is fantastic. Awesome. I'm
Great.
going to get rid of that question and answer block right now so we can see all of that going. Fantastic. And thank you for troubleshooting all of that on the behind the scenes, Susan. It takes a village to make this all happen, right? That's awesome. So the next video then, same dog, different context.
Chris, why don't you describe some of the phenotypes on this one, because it's a little bit choppier.
Yeah, absolutely. So here we've got a dog that's out in public space and different from the previous video where we had the dog's sort of attention very clearly focused on individual points within the environment. Here we've got more what I would consider hypervigilance, where we have an animal who is frequently looking behind them. We're getting that sort of looking over the shoulder. They're getting that loss of selective attention rather than focusing or fixating in one particular place and processing whatever that information is. They're vigilant. They're trying to keep track of all of the data points all at the same time. And that's one of the main things that differentiates a fear response, direct relationship to identifiable stimulus, from anxiety or an apprehensive anticipation of threat. And obviously, as you're seeing in this animal, they can be comorbid conditions, but they're not automatically the same thing. even though we often lump them together when we talk about things like fear, anxiety, and stress. And so one of the challenges that we have in animal who is experiencing more anxiety is they often struggle to focus. So if we were trying to train this dog or even to ask them to take a food treat in this environment, that may be difficult for the animal to focus or attend on that stimulus of handler interaction or food delivery for long enough without their attention being shifted back to what we're seeing. We also see that startle response where those really rapid attentional shifts, as opposed to an animal who is scanning and attending to all of the things in their environment more smoothly. Any additional thoughts or questions on that one? And again, feel free to throw any questions or comments into the chat as we now that that's working. We'll be keeping an eye on those things, and we'll be sort of folding in questions along the way, as well as leaving some time at the end for some Q&A. So if you have any comments or questions, or if any of this lands well for you, by all means, let us know that in the chat, and we'll keep that going. Let's take a look at the next ones. So here we're looking at more motor patterns, as you see, pacing, circling, spinning, and so on. We'll take a look at the first one. This is the point where I typically say, not it.
Yeah.
Right. This
so
one's not me.
Again, we're looking for, I don't want to harp on it too long, but laterality to you should be nearly a pathognomonic sign, flashcard. If lateralized, then very, very unlikely to behavioral. And, what we're going to see in some of the other videos of these signs is these dogs that have compulsive circling is going to be because of a forebrain issue. The reason why animals with forebrain disease do this is what's known as an aversion or hemi-neglect syndrome. So the equivalent in humans is somebody goes into the neurologist's office. They say, I feel a little bit funny. I'm having some kind of weird mood swings. And then when they come in, they've shaved only one side of their face. And then the neurologist says, oh, that's really weird. Why don't you draw this clock for me? And instead of drawing 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, they draw 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And the reason for that is the forebrain is so important for attention, for focus, for at any point in time, we're getting millions of points of stimulus. So our brain has to basically filter all that out and decide what's important. And that doesn't work right if you have a brain lesion. So long and short of it is, in dogs, when they have a problem on this side of their head, they're not paying attention to this side of their body. And so as a consequence of that, they tend to circle towards the problem. They'll tend to eat out of one side of the bowl that's on the side of the problem. They will tend to respond to you out of that side. And so if you see that, that's suggestive of a forebrain disease. And it makes sense, Chris, that would cause behavioral abnormalities as well, because as you recall in the beginning, we said forebrain is the location of behavior. In humans, they have a prefrontal cortex. This is where it all starts. So this is where we get to overlap a little bit.
Yeah, absolutely. And I love when we start talking about sort of the cognitive processing, right? So oftentimes when we get into the emotional side of things, I often describe it to my clients, it's almost like a teeter-totter rather than sort of a right-left. It's sort of like a limbic system to prefrontal cortex, right? And we're all sort of designed so that if we get that emotional activation, and if our body is perceiving fight-flight type stimuli, it essentially overrides cognition, but it doesn't lateralize. We don't see the right-left piece with that. We see an animal who may be struggling to attend or is processing stimuli in sort of an abnormal pattern, but this right-left piece is not something that we expect to see when we're talking about that balance between cortex and limbic system. So totally different balance, which is fascinating. Diane, I see your comment. Can we do this every week? Sure. Sure, Fred and I will we'll sign up for that. We'll get some sponsors. We'll make that happen. Anything else on this video, Fred, before we move to the next one? Awesome. So let's take a look at this next dog. And again, sort of the big picture question here, behavior or neuro? Behavior or neuro? If you've got a thought, throw it in the chat. do you think? Behavior or neuro? Is this you or is it me, Fred?
Yeah, I think this is one of those troublesome ones that can be difficult and that you have to ask a few more questions, right? So is that the way the dog is all the time, or is it not? And I think that that's another good distinguishing factor that we use a lot of time from behavior versus neuro is this happening all the time? Is this happening in a single environment, or is it happening in a different environment? Can you stop these activities, or dare I say behaviors, those sorts of questions? But I think he's tricky, she.
Yeah, I agree. I think this is one of those cases where if you found yourself going solidly in one direction, thinking, oh, it's definitely this, I would want to roll that back a little bit, right? Because when you think about some of our differential diagnoses, this could be an animal, and again, I'm just going to throw out a couple of hypotheses here. You see there's the covering or on the floor. Maybe this is an animal who's having incontinence issues, so it's been confined, but it has a confinement aversion. So this is a distress response that we're seeing with this pacing and the animal can't settle. Maybe this is a dog who has cognitive dysfunction. And so that pacing is actually an impairment of cognition and the ability for them to process their environment. Maybe this is a dog with separation anxiety, and we're seeing this as an anxiety response. So when we're thinking about what we're seeing here, and just to describe the video, Jane, I see your comment in the chat about the choppy video. So here we've got a dog who's in a confined space and is moving relatively fluidly, but isn't settling. We're not seeing a shake off. We're not seeing any overt signs that the animal is settling into their environment, nor are they really attending to or interacting with the environment itself. It's a bit more of a ritualized movement. So this would definitely be one we'd want to know a lot more information about before we made any conclusions. Should we take a look at the next one? Excellent.
Good afternoon, Debbie. This is Eric Spencer. I'm from WSU Veterinary teaching.
See if you get him circling again, I'll take them.
Here, Gus Blessing. I was just wondering if Mrs. Budger said that there has been some recent blood work performed on Gus. I just wanted to see if this is my accident over this.
Yeah, so we can kind of cruise through this one a little bit, but what I'm seeing with this dog again is that compulsive behavior that I'd mentioned to you before. And I think one of the things that you'll notice, two things I want to point out. One is that this dog was head pressing at the beginning, another sign of forebrain disease. If you see that, it's usually suggestive of what we interpret now, perhaps anthropomorphizing too much, as a headache or a migraine. And the suspicion is that's what that is. Another thing I'd like for you to note is that despite the fact that as that dog was walking around, it would scuff its right front leg very rarely, but there was no signs of ataxia there. And I think the reason that's important to remember is that the forebrain is responsible for a lot of things, but gait generation actually happens caudal to it in the midbrain. And so most of the animals that have forebrain disease tend to not be ataxic. So keep an eye out for that. I see a note of the hypoglossal involvement, which I'm really excited about. So the tongue hanging out, obviously the hypoglossal nerve controls the muscles of the tongue, a lower motor neuron. We can talk about that in different rounds, but that has to be controlled from higher up. And so if you, any of you watched ER, Michael Crichton, genius, so if we watch Mark Green, the way they knew he had a brain tumor is they asked him to stick his tongue out, and Susan said, stick your tongue all the way out, and he moved it to the left. And that's how they knew that he had a right-sided brain tumor. So tongue abnormalities are no different than anything else on that side of the body. It can be associated with a forebrain lesion.
I love that. Again, lateralization, right? If we have an animal who is stressed and is pacing truly to more of a compulsive pattern, we don't expect to see that lateralization, even though the tongue may be extended with panting, especially if we're getting a full horizontal lip retraction through that kind of a grimaced face when we have a stressed out animal. We're not going to see the right-left involvement that's going to be more evident in the neuro side of things. Let's take a look and compare that to the next video, and this will move a little bit quickly. So again, I hope that the video comes through smoothly enough to be able to differentiate that. So here we have about a 5-month-old shepherd in a consultation room, repetitive movement in a circular direction to the right thus far. There we've got left. And although he was a little bit clumsy, I didn't necessarily see anything that to me that suggested ataxia. He strikes me more as a poorly coordinated 5-month-old dog who's probably a bit exhausted, as opposed to seeing an overt ataxia. Do you see anything different within that one, Fred?
No, I agree. And I think a forebrain dog, they're going to have compulsive movements in the absence of ataxia. But I think the thing for me, in addition to the bilateral movements, is he's targeting something. You can actually watch him target something on the ground, as opposed to a forebrain dog with a structural lesion. They may be dull, they may be disoriented, they may be obtunded, whatever words you want to use, they're all the same thing. But what that dog is doing is interacting as normally as it would, just towards one side of its body, as opposed to this dog that's having a very kind of goal-oriented, task-oriented type of movement. And for me, that's a big distinguishing factor.
Yeah, absolutely. I think it's a really important detail with so many of the true compulsive behaviors. We'll see a couple other examples of those here shortly, but they do tend to be very goal-oriented. There's a specific motor pattern. There's an interaction that's occurring. And oftentimes when they're starting, there is some sort of a stimulus that prompted that, whether it's in this case thinking about a 5-month-old shepherd. We want to make sure that we're looking at our medical differentials as well. So doing a rectal, palpating the anal glands, the anal sacs, looking at radiographs of the hips and lower lumbar area, doing an orthopedic exam, doing a neuro exam, looking for any source of discomfort, even doing a comprehensive derm exam, just really making sure that there's not some source of discomfort, neurosensory input, some stimulus that's eliciting that reaction. True compulsion, when we get far enough down that pathway where we're truly using that label, tends to be emancipated from the stimulus. So it's now occurring due to more of an internal motivation that may be more dopamine related in some animals, in others not so much. But we tend to see more of that pattern that is less triggered the way we would see with other perhaps fear-based issues. So some really important distinctions to really figure out which pathway we're looking at. I see the comment about this particular dog also stopping at the door. Is it distractible? And he's variably distractible. The interesting thing about this particular dog, and it's difficult to see even when the video is going smoothly, is that when you try to distract him, you'll get a little bit of an ear flick. So there's an acknowledgement, even if it doesn't interrupt the motor pattern. And for me, that's an important thing to be able to differentiate. Can he hear me? Is his brain processing the fact that there's new sensory input as I'm calling his name is actually a different detail as to whether or not it stopped the behavior, which may have to do more with social, either suppression, social pressure, or even just the relationship that he has to the individual who's calling his name. So again, these relationships really matter. We'll take a look at one more movement pattern, and then we'll look at some quote unquote fly snapping behaviors.
Sometimes it's like hard to really
You're fine.
get his attention to snap him out of it.
So here, not seeing any level of ataxia or lateralization, but very much a
Do you have specific
patterned,
patterns in the house as well as outside?
directed behavior.
Yeah.
And he'll see he does this turnaround thing.
Every time you put this video up, Chris, I feel the anxiety myself.
There's
Yeah.
You just feel that tension. It's like, oh, I just want everybody to breathe.
Yeah.
And so you could argue, well, because he makes those turns so accurately, he's interacting with the environment, but this isn't quote unquote normal behavior.
Yeah, I noticed he has one particular favorite chair over here at the table.
Even the
that
social
corner
interactions,
is
essentially
directly opposite
bowling
direction.
right into the other dog in the household. This
Yep.
is not an interaction that's happening. This is a repetitive, stereotypic, compulsive pattern that I would argue is probably more me, but I would want to know some other questions, right? If this is an acute onset, do we have any abnormalities on our neuro exam? Is there any possibility that this could be actually happening due to some other underlying structural or functional abnormality? Is that something that you see, Fred, when you see some of these patterns in certain cases, or at least ruling that out?
Yeah, I mean, I think it's we, one of the challenges is always a behavioral problem can always be a structural problem, but a structural problem can't always be a behavioral problem, And so, yeah, whenever I see a case that I think to myself, this is definitely going to be something I need to refer to Chris. One of the things that's always on the table is saying, do we want to take tumor out of the equation? Do we want to take a brain malformation out of the equation? And, the limitations on that in the animal world are greater than they are in the human world, right? I think you'd be hard pressed to have a severe mental disorder and not get an MRI. But in the dog world, we have costs, we have anesthetics. And so, yeah, I think there's always that consideration for that diagnostic.
Yeah, it's fascinating to be able to really tease that out. I'm thinking of one case in particular who's not in this presentation that we were seeing in the behavior clinic for a variety of what looked like emotional issues, fear-based reactions and reactivity, impulsive reactions, and so on. And yet when we started to go into the behavior modification pathway and really starting to work with that dog, he was really slow to learn. Just really, really like impressively slow to pick up on new patterns, to the point where we were really struggling to make advancements with him. And eventually, thankfully, they had insurance and they ended up going to the point of doing an MRI, and they found a brain lesion. And so the neurologist read it out as saying, no, I'm sure that's not a functional lesion. We see that all the time. And yet I'm looking at that dog saying, his brain isn't working the way that it should. And so we have this overlap there of being able to really tease those things out based on the phenotypic expression, as well as some of the imaging results as well. I'll have to pull that case for when we do this lecture again. I've got some videos of Teton. That'll be fun. Let's take a look at some fly snappers and look at a different pattern that's very, very, very much different from what we've talked about so far. We've got a couple of different variations of this one. The visual here is just a little bit fuzzy. We'll get a couple of clearer images here, but wanted to give you a couple of different examples. For those of you who are watching and sort of thinking about these cases, when you see an animal who's engaging in a behavior that looks like this or looking at this motor pattern, what do you think's going on? Where would you refer them? What body systems are we looking to really lean into, either from a diagnostics or a treatment standpoint? Go ahead and throw some comments in the chat if you've got a thought, even if the video is not coming through perfectly smooth for you. Yeah. Fly snapping, where do we send them? While we're putting some of those comments in, I'm going to go ahead and play the next video as well.
Yeah, and I'll talk over it if that's all right, Chris, while you keep going.
Yeah.
So when we see fly snapping or fly biting, I see a lot of focal seizures out there. And so when you see these are known as complex focal seizures. They're a more complicated movement. They're not like this. They're more complex movements. So that's why they're called focal complex seizures. And remember that a seizure is a paroxysm, meaning it's an event that starts with no onset and really doesn't have any specific end. It just kind of comes and goes, right? So they can be a number of different things. But when I see a focal complex event like this, what this basically means is that there's a problem in the motor cortex. Not dissimilar than if you had a problem in the sensory cortex, you might feel something funny crawling on your arm. Or if you had one in the limbic center, you might vomit. So when I see focal complex fly biting seizures, the thing that your brain should immediately go to is distemper. That's kind of the etiology that's associated with complex fly biting seizures. But there's other paroxysms and other things that can do this. I see a lot of people put on their Chiari malformation or caudal occipital malformation syndrome. You notice that these are both King Charles Cavalier Spaniels predisposed to that. And certainly there's a weak association between fly biting and that, but it's definitely there. The one that we want to draw your attention to most is going to be, am I okay to continue here, Chris?
Yeah, go for it.
The one that we are really most interested in at the moment is gastrointestinal disease, specifically gastroesophageal reflux disease. There was a paper that came out not too long ago that showed that fly biting in many, many dogs is a sign of esophagitis. And what they're doing is extending their esophagus, kind of like when you have heartburn. It's the way to resolve it for them. And the way they did that is by empiric treatments with a combination of usually steroids, a proton pump inhibitor like omeprazole, sometimes metronidazole. And what they were able to do is resolve the fly biting, and they did actually coax postulates, meaning that they resolved the disease, then they took away the treatment, the disease came back, and then they reinstituted treatment and it went away again. So when I see a fly biter, my brain goes first to GI because it's more practical to treat and it's more inexpensive to treat. And then if unsuccessful, I reach for other things. One thing I want to mention that I always forget is that zonisamide is often thought of as a focal complex anti-seizure drug. And it's very effective against these guys, but remember as a sulfa drug that it can have some benefit on the GI system as well. So I try to stay away from zonisamide in these cases because I want to know what I'm treating before I reach for that drug.
It's a great point. Before I play the last video here, and again, to kind of think about that motor pattern and how it shows up in such a repetitive way that may have us thinking, oh, this is a seizure because it's so consistent, or it's a compulsive disorder because it's so ritualized. You know, this was something that I remember when I was first learning about that GI component to it. I remember reading through some of the literature on the human side as well. And this is something that, especially with that sort of neck extension, and that in some cases on the human side, actually, there's a condition in infants called Sandifer syndrome that was originally thought to be a neurologic disorder as well, because these infants were going through these body contortions. And until they figured out that they were actually, again, more of an esophagitis, and they were actually, you know, kind of trying to relieve that discomfort, and they were seeing it more as a GI colicky type syndrome. And once they resolved the GI issues, the neuroscience, quote unquote, neuroscience went away. So we see that very similar correlation. Playing you one more video to again really emphasize that extension of the neck that shows up in the vast majority of these cases. So this was a dog that came into the animal behavior clinic after having failed multiple treatment trials with antidepressant type medications, anti-anxiety medications, anti-convulsant medications, anti-inflammatory and pain control medications, but nothing yet had been attempted from the GI standpoint. So I said, well, before we start going down any other pathways, let's make sure that we've addressed that component as well. Sent them back for GI imaging. They were going to go ahead and scope and identify whatever else was going on for this particular pup. So it's definitely worth ruling out. And if that's a new piece of information for you, you're going to be in much better shape when you see these next cases coming through. So thinking about, you know, a lot of what we've talked about so far, you know, when Fred and I were talking through this discussion, again, a lot of different things come to mind for us, right? As we're looking at the individual videos, we're looking at individual patients, and we're looking at different ways of assessing the information in front of us. In some cases, we're gathering the information from our hands-on examination or observation in real time or perhaps on video. In other cases, especially on the neuro side, there's certain things that we're not going to be able to see from a hands-on exam standpoint. We're going to need to go to imaging. And then there's some of those diagnostics that we need to run. It's not that we need to run all of these things for every patient, but being able to get that sense of your differential diagnosis list to say what's more likely, just in the way that Dr. Wininger just described with those fly biters or those fly snappers, go GI first. It's more accessible, it's less expensive. We're going to see a response if that's what it is before we go down other pathways. So getting that ranking system as well, it gives us such a better way of being able to really think about which approach we need to go with, keeping in mind that not all diagnostics, not all modalities are going to be accessible, whether that's limits that you have in practice based on where and how you practice, or whether that's financial limitations for clients, right? You may be saying, I really want that MRI, but I don't get it. I don't get to have that for this particular patient. So I'm going to do the best I can with the information that I'm given. And then maybe we're backing our way into responses by looking at how they responded to what we did, right? So you may be throwing some medication at those patients to see how they respond, and you're making your decisions based on what you've got access to. You know, and I think sometimes, you know, I always think about this in like, well, the gold standard is getting the diagnosis first, and then this is, well, if we have to. There are some of our patterns that it's really difficult to tease them out. And we may be talking about diagnoses of exclusion in some cases, if we're talking about something like cognitive dysfunction, for example. which again is another point of overlap between Fred and myself. It's a neurodegenerative condition, but it manifests as behavior and cognition changes. So who is it? Is it him? Is it me? Which one? Where did we go? So we're looking at the response to interventions here as well as a way of trying to figure out exactly what's going on for a particular patient. What that also means is that in some cases, we're able to be really specific. As we were with some of these cases saying, this is what this is. This is a pathognomonic lesion. I know exactly what I'm going to be doing. In other cases, we may be going a bit more general. A bit more saying, well, I'm not 100% sure what's going on, so I'm going to try to back my way in. Maybe we're going down an exploratory route, not sure what we're going to find. Maybe we're going down the pathway you see on the right-hand side of the slide here. You see the Calmer canine device on a couple of different dogs. That's something that's been shown to be effective in the treatment of separation anxiety. So we may be going down that pathway because of a very specific diagnosis. And also, I've got some clinical evidence to say, well, at least anecdotally, it may be helpful for other anxiety conditions as well. So if we're trying to figure out how a patient might respond to that particular modality, or maybe we're trying for some pain control and we're using the Assisi loop or the Assisi lounge, we have the option of then trialing different therapies, evaluating the clinical response, and then using that to inform whatever we do next. Anything else you want to add on those slides, Fred, before we go back into some videos?
No, let's keep going.
Excellent. So here, coming back into some different motor patterns and kind of, these we clustered from the what are they seeing standpoint. And we'll let the first one play here, and then we'll come back into some discussion.
Minnie, come touch me. Good girl.
So the owner called her over, asked her to do a hand target. She responded and then returned back over to that window. So like Fred was talking about before, you see that intense focus. You see that goal-directed behavior. So this is a dog, when we look at when this happens versus when it doesn't happen, this is something that's happening on bright sunny days or when there are significant reflections in the environment, and her focus is going to be drawn to those reflections or flashes of light. She can be called away, but also this is something that she will do if not otherwise directed. We're not seeing any evidence of ataxia or any other lesions on neuroexamination, so I would be treating this more as a behavioral pattern rather than thinking about neuro for all of those reasons. Any other thoughts there before we get to a couple of the next videos, Fred?
I think the only thing I wanted to add, and you could start playing the next one as I say this, is when we think about paroxysms, when we think about seizures, a lot of us were taught in veterinary school that a dog can't be conscious when they have a seizure, and that's not true. So I think that behaviors like that, even if they can be distracted, don't necessarily mean it's not a seizure. I purposely talked over that video because I was hoping to see what its quality would be. But can you play it one more time? It's a little bit choppy.
It's okay. You got it. Keep going.
What you're seeing in this dog is that it's walking down the street.
Oh, you got it, girl.
And then it retracts really quickly. And there's no stimulus that seems to do that. So when we see a dog kind of move away from something, obviously you think about a startle reflex or a startle response, I should say. But when you see that kind of no stimulus is causing it, there's no consistencies between it, I always ask the owner, is there something that's happening that makes you think that that's happening? And they say, no, there's nothing different. It just out of nowhere, they flash. I think we have to be thinking about, again, those complex focal seizures. Now, what I often tell clients and referring veterinarians is, you have your 7-year-old or 8-year-old patient that comes in with something that's suspicious of a seizure. That's a blessing. And they look at me and they're like, I'm not here for a blessing. I mean, this is not a good thing. But the reason why I suggest it's a blessing is this. And I tell my colleague or my colleagues or my clients about a friend of mine. He was playing soccer. He headed a ball. And after he headed the ball, he developed some double vision. And that double vision did not get better over the course of 2 weeks. He went to see a neurologist, and they did an MRI, and they found that that dog had a brain, or that Matt had a brain tumor. And so in dogs, they can't tell you that they smell triangles or they taste red. You know, they can't describe to you that there's miswiring in their brain. And so the only way we know that they have a problem is one, behavioral abnormalities, which are hard to pick up on. I could tell you all the time, I have clients come in that are upset they didn't bring their dog in earlier when he was just acting off. But how would they know? Two is seizures. And three is going to be some type of locomotor abnormality or postural reaction abnormality, some inability of the appendicular skeleton, right? And the problem is that when we get to that point where we're starting to affect the sensory or motor cortices, we're getting to a point where our ability to intervene is much poorer. So fortunately, seizures can emerge in parts of the brain that are not that important. Remember, just like the movies say, we only use 10% of our brains. To some degree, it's true. We have all these non-functional areas in our brain that don't do a whole lot, but they still can be a seizure cause. The whole reason I mention this is we have to kind of flip the script on our clients and remind them that seizures are not a disease, they're a symptom or a clinical sign. And after the age of 7, the likelihood that that symptom is caused by idiopathic epilepsy, as opposed to something more nefarious, goes up by multitudes. And so if you see something like that, that's a place where a primary care veterinarian could say, that's not behavioral, that looks like a complex focal seizure. I think you need to get that addressed right now if it's something you'd be interested in. Chris, while you go play the next one, I was just going to answer Dr. Cook. I believe that Dr. Cook is a neurology colleague of mine, and he was mentioning that some of the whipworms, typhlitis, and a lot of other kind of large bowel stuff can also cause some of these weird behavioral abnormalities. And that certainly was something that was discussed on the listserv, so something to keep in mind. So unfortunately, this video is a little choppy, but this dog is doing something kind of similar to the previous dog, where he's walking around without any input and he goes kind of like that. And so the reason I like this case is it is another example of complex focal seizures. But this is a case where we want to start recognizing that epilepsy is not just a single disease. It's a group of hundreds of diseases that have been thrown into this garbage can. And so as we start to understand epilepsy more, we can start combining signalment, age, breed, sex of the dog with the onset and the type of seizures. So if I see a complex focal motor seizure in a dachshund and they're from London or Britain, I'm thinking to myself that that's a disease called Lafour's disease, a very specific form of myoclonic epilepsy. The reason I like that video so much is, one, is it demonstrates a complex focal seizure, but also the knowledge that we're moving neurology out of the MRI and back into your clinics. What you'll notice is that most of these dogs are being filmed at home. And so the most powerful piece of technology we have, whether it's behavior or neurology, is probably the mobile device. And you have this dog with this very characteristic phenotype, and we can work together to figure it out.
Yeah, one of the things that I love about that particular video as well, Fred, is, when you initially are describing that and you're sort of doing that sort of startle and that recoil movement, that could very much look like an animal who is startling and avoiding some sort of a stimuli. And yet, one of the things that really strikes me from the behavior lens is that if this is a dog who is startling because of, let's say, an acoustic trigger, a car backfiring in the distance, we will typically see that recoil tends to move away from the source of the sound. So as the stimulus changes, the body language changes in response, and we don't see that here. So that would put, the auditory stimulus a little bit farther down on my list. If there was something in this animal's environment that was eliciting that startle response as it's moving forward and it's recoiling, I wouldn't then expect it to immediately recover and start marching forward again with its little toddling walk that we see in this video. So the fact that it recoils but then immediately moves confidently forward would also argue against this being a primary fear-based or startle response that's happening for emotional reasons. I'd be looking more at that motor pattern, what's going on that's causing that as well. So even though I wouldn't have a fraction of the knowledge in my head to describe everything that Dr. Wininger just said about what this is, I'm going to look at this video and say, I know what it's not. This is not a primary fear or anxiety response because of X, Y, and Z. And as a behaviorist, I'm going to be able to give that information confidently to my client, and then pass them off to Dr. Wininger to be able to address that from there. And so, one of the things that happens in these particular videos, and I see your comment there, Michelle, about startling from pain. Absolutely, we can absolutely see animals where we see those motor patterns that are a result of pain or discomfort. And I would say, at least in the majority of my cases, if I have an animal who, let's say, I'm going to say experiences a twinge because of a neurogenic pain, there's a bit of a twinge, or maybe it's an ACL issue. We then see in those seconds that follow some degree of avoidance. Maybe it's a reluctance to use that limb, or it's a slowing down of movement, or a much more intentional placement throughout the environment. So when there's a pain stimulus, it's uncommon, at least from the majority of the issues that we see, for them to then immediately recover and move forward again. And so that pain response tends to look a little bit different as well, but it absolutely should be on your differential list as something that could also be a factor here. And I see the comment there about, the choppiness of the video, and it's one of the things that Fred and I had chatted about before doing this. It's difficult to do this unless we pre-record and have it all ready to be able to push out in a different way, to be able to get the videos to guarantee to come smoothly through. So it's something that's out of our control, based on how they're coming through on the individual user end. We got one more video here, which kind of harkens back a little bit more to, again, as we've talked about, one dog who's more goal directed, and then a couple of dogs that are responding more spontaneously with more of that motor pattern. The last video here kind of goes back to the first one. So here we again have a dog who's now in an outdoor environment. To Dr. Wininger's point, this is a video at home. The client who says, hey, my dog is fixating. He just stands out in the yard and stares up at the sky for potentially hours at a time. Is that compulsive disorder? Is he seeing something that's not there? If that's the only description that I get from my client, I'm not actually going to be able to answer their question. I need to see video. Here, what I really appreciate about this particular dog is the diversity of movement patterns. I'm seeing some slow intentional focus. I'm seeing some bounding. I'm seeing rights. I'm seeing left movements. I'm seeing a lot of attention upward, which is going to make me ask the question, even though we're not seeing any particular stimuli triggering that here now, I may ask the question, are there particular triggers that elicit this behavior? And the owner would then tell me, given the history for this case, well, he will do this when there are squirrels or birds in the trees, but he also does this when those stimuli are not immediately present. And that's one of the fascinating things about predatory responses and dopamine circuit-driven behaviors. And it's actually the possibility of having something to react to. It's the hunt, it's the chase that elicits that sort of almost gamification of their life response in the backyard that keeps it going. So it's not always having to be stimulus driven. It's the possibility of there being something to react to that's present. So you see the different patterns in these different behaviors. Anything to add? Fabulous. Let's take a look before we wrap up. Let's take a look at a couple of these pups.
Can you want to stimulate him with sound?
Hey, bud.
Okay, now if you put your hands on him.
This was my case, and it was pretty fascinating. So the owner wasn't super worried. She just was kind of curious as to what was causing it. And the dog developed this kind of funky ear movement. And what you can see in the video is that the ears start to flick and flicker more as the dog is excited by auditory stimuli, but not by other stimuli. And so the reason I like this video is to demonstrate that these focal motor movements that are happening all the time, they can be difficult to get to the bottom of. Unfortunately, we never figured out which one that was. Maybe Dr. Cook knows out there, but kind of unusual behavior and unusual motor movements, since some of these will be a little bit different upcoming.
As a differential standpoint as well, someone asked when at a previous presentation, they said, well, could you see something like that for a dog who has otitis? and you're seeing that ear flick. And yet when you look at the whole pattern, it's not the entire ear that's moving. We're also not seeing any scratching or rubbing or attention to that area the way we typically see with otitis externa or otitis media when we're getting more of that response, more of the discomfort that's there. Could it be behavioral, meaning we sometimes see dogs who will move their ears in response to fear or anxiety? Maybe. But I'm not getting any other body language changes. I'm not getting widening of the eyes. I'm not getting avoidance patterns. I'm not seeing any sort of changes within the lips or the overall kind of the communication centers within the face. We're just seeing this independent movement that's happening, which would argue against a primary emotional pattern, knowing that when we have an animal who's trying to communicate an emotional state, we often see redundant patterns across multiple body parts as a way of really cementing that communication from one individual to the next.
Yeah, and while we start working on the next one, you know, a nod that I'd give to these involuntary motor movements like Jane has put down there is there's a new group of diseases that are emerging in the interest of the neurologist called paroxysmal dyskinesias. They're basically abnormal focal motor movements that aren't reminiscent of classic seizure behavior. They tend not to emanate from classic focal seizure places. And the reason why they're of particular interest as of late, as opposed to previously where they were called cramping disorders like Scotty cramp or deer stalking or Ballism or whatever else other descriptor you want to give to it, is that there's been both a genetic and also a phenotypic response to a gluten sensitivity. So a lot of these animals, we put them on Royal Canin Ultimino or some other gluten sensitive diet, and a lot of these behaviors will go away. I never attempted it on this dog, and to be candid, this doesn't really look like a paroxysmal dyskinesia. Usually it's more of a retraction of the non-anti-gravity muscles. Usually it's asymmetric, and usually it's more held in place rather than this constant flick, but kind of interesting.
Excellent. Ready for the next one? Perfect.
Chris, why don't you describe what you're seeing here, because it's a little bit choppy.
For sure. So here I've got a dog that's in a home environment. So starting out there in one, the first little clip there, the animal was held, and now we're seeing the similar pattern is happening when it's not held in the arms. Again, back to being held again. We're also seeing it labeled, and it's happening across multiple days. The motor pattern is, and I'll be curious to hear how you describe this as well. The interesting thing about the motor pattern that's more of a trembling or a shaking does not appear to be associated with any other body language changes. Again, I'm not seeing it correlating with eye movements. I'm not seeing it correlating with additional changes in the facial expression or posture. I'm not seeing it as part of a recoil or an avoidance response. It's something that it seems to be relatively similar across multiple variations in terms of days, positions, postures, held, not held, and so on. What else do you see?
Yeah, I think if this had been any other breed or any other group of dogs, I'd say, yeah, it looks like tremors secondary to anxiety or excitement or any of the other descriptors of kind of a high sympathetic tone, if you will. But I think that when I start encountering toy breed dogs, particularly middle-aged toy breed dogs, particularly females, obviously this one is not a female based on this, I do start worrying about a lot of the inflammatory disorders that are emerging, because they can present for a variety of things from behavior to tremor movements. And Chris, if you'll jump ahead to the white dog, we see a more classic appearance of kind of a tremoring or kind of muscle fasciculating movement there. Now, it gives us an opportunity here to talk briefly about the difference between a tremor and a muscle fasciculation. So when a dog is anxious, usually they do a little bit of a shimmer, a little muscle fasciculation, which is a group of myofibers that are all kind of firing at the same time when they shouldn't. So it looks something like this, like that, right? As opposed to a tremor. Well, why does a tremor start? A tremor is a oscillatory movement of antagonistic muscles. So that's a fancy word. What does that mean? Well, what that means is that I have a bicep and a tricep, and right now I can keep my arm in place because I'm flexing both of them at the exact right tension. But if my bicep was a little bit stronger or getting a little bit more input, then my tricep would try to compensate, and then my bicep would try to compensate, and then when my tricep would try to compensate, before you know it, you start getting a tremor. So a lot of tremors are because of an imbalance in muscle tone, not necessarily emanating from the muscles, but perhaps from the controlling centers. And the place where we tend to see that controlling center most is likely the cerebellum. So if you have inflammation of the cerebellum, often associated with inflammatory diseases, you might see those coarse tremors. Of course, in that white dog, it's shaking, so you might be thinking about little white shaker syndrome, also known as cerebellitis.
Yeah. I want to contrast that to the last video that we see on this particular slide, where we see a dog that is now standing on the dining room table, relatively stationary. It's not actively moving, at least not a lot. Tail is tucked, ears are pulled back, body tension, and a full body sort of shaking or tremoring. This is contingent. This is something that doesn't happen spontaneously. This is something that happens in response to the teenage boy's roughhousing. So we now have a relationship. This is now something where we say, well, this is the antecedent. These are the situations, the circumstances, the environment under which this behavior is observed. At the end of this, once the boys are no longer roughhousing, Toby will, at some point, give a shake off. He'll recover, he'll release that body tension, and he'll resume more normal interactions until the next trigger. But here we've got a relationship between the observed behavior and the stimuli that precedes it. And again, the redundancy within the body language, inhibited body movements, ears back, wide eye, tense facial musculature, tucked tail, all of those things that give a very similar message that allow us to say with confidence this is more likely to be a fear or anxiety or stress response as opposed to a primary physical or neurologic condition. Anything else on any of those to differentiate those, Dr. Wininger? It looks like you're muted still there, Fred.
Oh, thank you. I know that video makes me think of this video I saw on Instagram today of this golden retriever watching Star Wars with his dad, and Darth Vader comes around and he just goes running around the back of the couch. So it's kind of fun to see that they're fearful of the same things we are. Neither here nor there, though.
Right, 100%. So, as we're coming to the end of our time here today, a couple of things, that we want to be able to address here, just to kind of call out, some of the things that we've been touching base on throughout this conversation today. Both Fred and I have commented video, video, video. These are so many of the conditions that we may see. And if you think about, our descriptions of that as clinicians, a behaviorist is going to see something different from a neurologist, is going to see something different from a dermatologist, from a generalist, we're all going to see something a little different, which is why having the video is so important, so that we can all objectively look at the same set of data to create those descriptions. So if we're only relying on our clients' descriptions, we're going to get a very skewed impression of what's actually going on. And some of what we're looking for within these patterns are, again, on the behavioral side, the antecedents. What are the triggers? What are the stimuli? What are the environments where patterns do or don't happen? And for any of these issues, whether we're talking more the physical or neurological or behavioral, we're often looking at frequency, or how does the pattern change over time? Was it acute onset and then gradual improvement? Was it a slow, steady, progressive worsening over time? Those patterns matter in terms of understanding the etiology of the condition, but also for evaluating response to treatment. If you have an animal that has I'm just going to use the example of a seizure. They have one seizure and you treat them preventively and they never have another seizure again, we actually don't have any data to know whether or not that animal needed to be treated with an anticonvulsant at all, because that may have been a one-off for reasons we don't understand. So having a baseline frequency of some duration allows us to then assess, did we make a difference with whatever treatment we're employing for that particular case, even for the things we were talking about with like the fly snappers, for example. If we're going to go down that empirical treatment of using some of the gastrointestinal medications, we kind of got to know what our baseline is, either in the expression, the severity, the frequency, the recovery time, something along those lines. Because all of the differentials matter, right? Even when we have similar patterns, similar motor movements, we could see those things happening for a variety of different reasons. And if you go automatically down one pathway versus the other, we're going to be wrong. And that's going to happen to you as much as it happens to me or happens to Fred. Well, I'm sure it never happens to Fred because he's a really smart guy. But for the rest of us, we've got to do that. And the last little take home point here, it really takes a village. Like these are cases that, again, this collaboration came to us by saying, hey, these are cases that came to me and I don't know what to do. What do you think? And vice versa. So at the moment any of us thinks we have all of the answers, we're missing something. So the ability to really lean on one another to get that information for our clients and our patients is just so incredibly important. Any additional thoughts before we go into wrap up, Dr. Wininger?
It's part of the wrap up, actually. So there's a question about cats, and I agree with you. Cats don't get their fair due, and neurologists in general, we love cats as pets, maybe not as much as patients. The rationale behind that being that if you do a neurologic examination on a species, they have to tell you the right answer every time if they're normal so that you know when there's something wrong. So that's what makes cats difficult. But I would say to those wondering about cats that overlap we talked about with behavior and structural lesions is even greater than cats. The most common cause for, or the most common clinical sign associated with a brain tumor in cat is a behavioral change. I see it all the time. Meningiomas make nice cats mean and mean cats nice. So if you have a senior cat, often people will check thyroid panels on them, especially in male cats. Makes sense to me. Do that first. But if you have a behavioral change, often a trip to the neurologist is what's most indicated. And that's not to trivialize that there's a lot more nuance there in differentiating behavior from neurologic feline abnormalities, but there's more crossover perhaps than there is in dogs.
I think it's a good point, Fred. And when we're thinking about either canines or felines, if there's a significant behavior change that happens acutely without other explanations, absolutely looking for, medical until proven otherwise. And especially on the canine side, an animal who's between, let's say, age 3 and 7, behaviorally pretty stable. Not a lot going on developmentally that should account for dramatic behavior changes. Same thing of cats from roughly age 2 to most cases age 9, 10, or 11, unless we're seeing some sort of osteoarthritic change or some other systemic problem. So we definitely want to be thinking about more of the medical issues.